Cheers to you, my doctor. Well, cheers to you, Rahabemos. I really appreciate the kind words. Another person, I have a question, and this is the one I want to really go through from Alex Angelo Abusiho. I have a question. What if a patient has an implant in his right humerus? That's the arm bone. And is it possible for him to undergo MRI of the lumbar spine? If not, is CT scan of the lumbar spine as effective in diagnosing lumbar disc herniation? And would CT scan of the lumbar spine be an equivalent as good a guide for interventional treatment of a lumbar disc herniation? Well, Alex, this is a great question. And so I understand that you have an implant in your humerus, your arm bone, and that it's made out of metal. And the first question is, if I have a metal implant in my arm, could I have an MRI of my low back? There's two things to unpack there. The first is, it depends on the metal. So non-ferromagnetic metals like titanium, not only are they more ductile, meaning you can bend them more times before they break, which make them good for medical implants, but one of the main reasons that they're utilized in orthopedic implants in places like the humerus, the arm bone, is that they are MRI compatible. They're MRI compatible. And then a question comes up not only with metals, like I broke a bone and I had a plate to stabilize it, but the question comes up all the time with implants, often pacemakers. I mean, the last thing you want to do is be in an MRI scanner and have the magnetic field of the MRI scanner mess with your pacemaker, right? I used to do even worse. I used to do brain implants for movement disorders. They're kind of like pacemakers, similar to pacemaker, but in the brain. And the tip was made out of metal, and metal heats up in an MRI scanner. So the fear was, what if these things heat up inside the brain? Could they actually cause brain damage? And the answer is, it depends on what the implant or the implant is made out of. Those non-ferromagnetic metals like titanium are fine. And then a lot of other things are not fine. And even in the same device, you can find some are okay because they've actually been manufactured in a way which makes them safe for MRI. They're now pacemakers and spinal cord stimulators that are shielded. The electronics are shielded, and so they're entirely safe. And the metals that are used in them are not going to heat up in an MRI. They're safe. And then there's others that are not. Well, how do you know? Well, you just, first of all, the imaging center is a really, really good guide. In fact, they're really the experts on this. They have lists of all the devices, and if you tell them the serial number on your device or the exact type of device it is, you should have gotten a little card either from the manufacturer or at the time of surgery, which will tell you exactly what the device is. If you tell the imaging center, they're able to look it up. In fact, this is such a big issue that before you have an MRI, you complete a safety, they have a checklist, and one of the things on the checklist is to have you fill out a survey. Do you have any metal in your body? Some people, Alex showed up in the chat and says that his implant is stainless steel and not titanium. Thank you for popping in, Alex. Yeah, stainless steel is 100% not safe. It is 100, you can pick up stainless steel with a magnet on your own. And so the metal implant in your arm is absolutely not safe for MRI. So that answers that. For everybody else, if you don't know, the imaging center can help you figure it out. And the key is to know exactly what's inside of you. Now, Alex knows it's stainless steel, but let's say he didn't know. How could you find out? Well, all implants are carefully logged and those logs maintained at the hospital in which they're done. So you can ask your surgeon. It's surprisingly, the surgeon may have retired, died, God, who knows. So if you don't have access to the surgeon, if you have access to the surgeon can look in their operative report and tell you exactly what the implant was. But even if you don't, the hospital's probably still there, and you can go to the hospital and ask the medical records department for the implant log and a copy of exactly what was implanted inside of you. All right, so now in Alex's case, most importantly in particular, we know for a fact it's not safe. Stainless steel is going to cause a problem with the MRI. And it causes a problem kind of in two ways. One way is the thing I mentioned, it heats up. So it even heats up inside your body. The MRI creates images by, it's a giant magnet, a giant tubular magnet, and it creates a uniform magnetic field. So all the, mostly water, but all the molecules in your body, they line up along that polar magnetic field. And then zzz, 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 there's a pulse that pushes them out of that alignment. And the degree to which they move out of alignment and come back releases a little bit of energy. And that little bit of energy is actually what they pick up to make the image. It's not like a photographic image where the light comes in. It's the energy that comes in and is detected by the ring. And that's how MRI creates an image. So what's the problem with the magnet? What's the problem with the metal? Well, the metal distorts the magnetic field. So Alex's stainless steel in his arm creates a distortion when the giant magnet tries to line up all of the water molecules and then pulls them off. The ones around here are screwed up by the presence of the metal. And that creates a real problem. The image is distorted, and that distortion creates inaccuracy. So number one, it's not safe because it heats up inside your body and heats up a lot. It can heat up to very unsafe temperatures depending on the degree of the various combination of metals in the stainless steel. But then there again, even if it did work, it would screw them up because it's going to mess up the images and the radiologist can't depend on what they're seeing. So that's not safe. All right, so either because you're like Alex, you've got stainless steel, you can't take that inside the MRI, or you have a device that could malfunction inside the MRI, and so you can't have it. You cannot have an MRI, and yet you're fearful that you have a herniated disc. Well, Alex brings up a great option, and that is a CT scan. So a CT scan is totally different from an MRI in the way that it works. The CT scan is actually based on x-rays, just like you have an x-ray, a chest x-ray or a dental x-ray. A radioactive particle goes through your body, and the more dense the material, the more it's going to prevent that particle from going through. So bones are super dense, so they prevent more particles from going through. And then on the x-ray, you see the particles that came through but inverted. So bone is actually dark on x-ray, but we invert it so it's white. The whiter something is, the more dense that it is. Now, a CT scan is an x-ray like that, but it's done tomographically. The T in CT is tomographic. And what that means is it actually takes a series of x-rays. And the kind of CT scanner that you're having your scan is actually the number of particle beams that go through you. It used to be that they were 8, and then there were 16, and then there were for a long time, they were 32. That means it's like having 32 x-rays, and then the computer reconstructs them all to get a three-dimensional image. Now it's 256. Do you think that's a lot of radiation? Yeah, it is. Well, it's 256 is a lot more than 16 or 32. So you can do the math yourself, but it's a lot. And so it is a lot of radiation, but it's really, really good for hard. It really shows bone. CT scan is really accurate in the abdomen. In the spine, it's really, really good for the bones of the spine and the joints of the spine. The disc, though, is made out of cartilage, and cartilage is low density. It's a soft tissue. And so the disc material is generally not easy to see on CT. And so CT is not as good as MRI at detecting a herniated disc, but it's still pretty darn good. And as a matter of fact, for many, many years, that's all we had. And, it was actually sort of before my time. This was more the 80s and the early 90s, but MRI was not as available and CT was. And, doctors did the best they could and it worked out pretty well. So CT is the number 2, the backup. If people like Alex, you really cannot have an MRI, CT is the backup to decide whether or not you need, if you need imaging, and it's not going to show up on x-ray, CT is better than nothing, that's for sure. Are there any other options? Yeah, well, there's one, and it's a combination of CT and myelography. Myelography is where they actually inject some dye in your spinal canal that can be seen on CT, and then it fills out the sleeves of the nerve root. This dye goes everywhere that the spinal fluid would go, and it shows if there's a disc there pushing, then you can see the channel that the nerve root should go through could be narrowed. Any volunteers? Probably not, right? You don't want to have an injection in your spinal canal if you don't have to, that's for sure. And who wants a dye put in their back? I would say CT scan is the way to go. And if I was, very rarely when I was practicing as a spine surgeon, as a neurosurgeon in spine, if I really thought there was something there and the patient couldn't have an MRI, but they had a CT and it didn't show it, but I was just convinced there was something there and I really thought the person could potentially benefit from treatment, then I would send them for the CT myelogram. But it's very, very, very uncommon. And Alex, there's a really good chance if you need imaging that the CT is the way to go. So, and don't forget, the indications for having the CT of your spine for a herniated disc are exactly the same as having an MRI would be. And that is, you're in week 3 to 6, no red flags, you have mostly leg pain with associated numbness or weakness. I should say after 3 weeks. The first 3 weeks, most get better on their own, so we try to wait it out. The reason to have that CT is to document the herniated disc so that you can decide whether you're a good candidate for an epidural injection. And then if that doesn't work by week 12, you can think about having microdiscectomy surgery in order to speed up the healing, because we know that whether you have microdiscectomy or not, pardon me, everything's the same at 2 years, right? But if you just say, hey, I'm 6 weeks and I can't do another 2 weeks of this, or you have functional numbness or weakness, or the pain is just unbearable, then microdiscectomy is really something to consider. So I hope that helps. A lot of information, I know, but and maybe overkill in some ways, but definitely go with that CT, and good luck to you, Alex. Let us know how it turns out. And by the way, if you get the CT and you want to review it on the show, we can upload it to our secure and private server, and then I can go over it with you. You can either call in or I can go over it on the show so that you can see. And that applies to all of you. If you have imaging and you would like a second opinion, it's free. I'm not a practicing doctor anymore, but I know a thing or two about this stuff. And I'm certainly happy to go over it so that not only you can know what's going on with you, but other people can benefit from understanding where you are. And as a group, we can figure out how to take the next evidence-based step forward. All right, Alex, thank you so much for that question. We got a couple more really good ones on YouTube. John Mitchell says, spinal fusion hurts even worse. Ask me how I know. How do you know? Let me know. I'd love to know. Spinal fusion is a big operation. There's no question about that. And so I'd love to know your experience with it. And then from Daisy one day ago, I gave up on trying to help most spinal stenosis patients because they A, refuse to lose weight, and B, refuse to do the PT and exercises, and C, refuse to get off their butts and move. I will make exceptions for people that come to me, but I no longer go to them. 99% of people I ever met did nothing to fix the issue and just want a magic fix. And then she goes on to talk about people being overweight and doing nothing, etc. Well, I take it from this, Daisy, that you are a physical therapist or a trainer. You didn't say, but I'm assuming you have some kind of therapeutic background, and you're frustrated with your spinal stenosis patients because they won't just get up and walk. And the reason you're frustrated is because you notice that when people do just get up and walk, they feel better. And motion is lotion, we often say with joints. That actually applies to spinal stenosis as well. But there's something, Daisy, that you really need to consider, and that is severity. When you start out with spinal stenosis, spinal narrowing, it is very, very painful, but you can actually do that motion is lotion thing. You can get up and walk, and the walking seems to really, really help with the pain. How do we know? Because the reverse is often the way spinal stenosis presents itself. Very often, a person was active, and then something happened that made them inactive. They broke their leg. One that I saw a lot of in my practice days was actually heart attack. I had a heart attack. I was in the hospital. I haven't walked in 3 weeks. I used to walk every day. I never had a problem. Now my back is killing me, and the pain shoots down my legs whenever I move. So they were keeping it at bay by staying active. But the reverse, that no longer applies. Remember, spinal stenosis is a progressive condition that never gets better. Even though you were active and it was feeling better, on the inside, if I would have done an MRI on you before the walk and then after you became active, after the walk, no matter how many days you walk, you still have spinal stenosis. If you believe otherwise, show me the evidence of that, because I've seen 20,000 of these, literally 20,000 patients in the course of my career, and never saw one where stenosis improved on MRI. It just doesn't. It only gets worse. So it may feel a little better. It may wax and wane. That's like saying, I can't see the moon, so it doesn't exist. No, right? I can't see the moon, but there's still a moon. It's just that I can't see it at the moment because the light angle is, the light reflecting off the sun isn't hitting me in a way that I can visualize it. But the moon is still there, people. It's the same thing with spinal stenosis. You may have gone for a walk and you feel better, but you still have spinal stenosis. And then as it progresses, you're going to reach a point where you really can't just walk it off. In fact, you can't walk. This is something in medicine that really is worth pointing out because it leads to a lot of wrong thinking and misinformation, and it's called selection bias. So if everyone who walks it off gets better, we would tend to think that all you got to do is walk it off to get better. If everyone who loses weight gets better, all you got to do is lose weight to get better. But that walking in particular, it's the opposite. The people who can get better can walk it off. If you can't walk, by definition, you can't walk it off. So you can't walk it off to get better, right? I mean, you can't walk because of the disease. And why is that? Well, let's go back to the screen. I want to show you something that might really, really help kind of clarify some of this stuff. So this is a picture. Let's see if I can make this a little bit bigger for you. I actually would. Yeah, that's a little better. Not great, but a little better. But okay. So this is a picture, and this person on the right is normal, and this person on the left has spinal stenosis. And just for orientation, this is a spinous process. Remember those bumps you feel at the bottom of your back? And then if we go down the side of it, we get to the flat bone called the lamina. And then this is the inside of a facet joint. And then there's another bone called the pedicle. The pedicle is, if you've heard of pedicle screws, that's where the screw goes in. And then we've got the disc. And so this is the bony canal, all of this, and then we have the same thing on the other side. Spinous process, lamina, facet joint, pedicle, disc. These are the boundaries of the spinal canal. Now in this image, this white is the empty space that's normally filled up with spinal fluid. So, and here of course is the spinal cord on the inside. So we've got the spinal cord, and then I want you to think of the spinal canal as a room. And our room has got a floor, which is the disc, and it has a roof, which is the lamina bones, and it has walls, which are the pedicle and the facet joints. The pedicle and the facet joints. So one thing that you don't see here is there's also, remember, a tendon connects a bone to a bone A tendon connects a muscle to a bone, but a ligament connects bone to bone. And so there's a ligament which goes right in here, and that's called the ligamentum flavum. And that ligament is not shown here, but the ligamentum flavum gets thicker with movement, and the joint enlarges as you age. I mean, think about it, people, right? Look back to me for a second. These are not the knuckles that I had as a child. They're much bigger. Joints enlarge with age and multiple cycles of force. And the facet joints in the lumbar spine, remember this guy facing you, the facet joints are joints. And as they bending forward, nice to meet you, bending backward, get away, getting forward, nice to meet you, get away, nice to meet you. You know, millions of times over the course of your life, the facet joints do just what the knuckle joints do, and they get bigger, and as they get bigger, what happens? The walls move in. So let's go look at the image again. Now, here's what happened. The facet joints enlarged, and so remember this empty space over here? It's not here anymore. The walls have moved in. And then they're not showing the ligamentum flavum, but the ligamentum flavum is along the roof, and the roof is coming down. So if your walls move in and your roof comes down, guess what? Walls move in, roofs come down. Your room is smaller. And now this thing is trapped. The spinal canal is more narrow, and your nerves in there in the lumbar spine, or your spinal cord up in the thoracic and cervical spines, is smushed. It's smushed in there, and that's the technical term. And so it's narrowed. And it's not just the spinal canal. Not shown in these diagrams are the foramina, which are the holes where the nerve roots come out. Well, your passageways, your holes where those roots come out, they're getting smushed too. Bone spurs are forming in there. And so you can even get nerve root pain from spinal stenosis. But classically, you get something called claudication. Claudication is pain down the legs when walking. Pain down the legs when walking. And you know someone's having claudication in the grocery store because they lean over the shopping cart. When you lean forward, it distracts those walls and opens that roof and creates more space in the spinal canal. It literally creates more space. Here's our guy laying on his tummy, and when he leans forward, see how it opens that canal up when he goes forward? When he goes back, it smushes it down. So you're in the grocery store and you have spinal stenosis and you start getting pain shooting down your legs, and you bend forward and lean on that grocery cart, and it opens it up and you can literally walk. Well, what if you're not in the grocery store? Well, classic spinal stenosis is you're out on a walk in the park and you feel that pain shooting down your legs. You bend over, you sit on a bench and bring your knees to your chest, just like leaning over that grocery cart. You want to bend that spinal canal open, and that more room after 4 or 5 minutes allows that spinal fluid to circulate and bring oxygen to those nerve roots, and they recover, and you feel better, and you can walk some more until it happens again. When this starts, it might happen to you after 30 minutes of walking or 40 minutes of walking or an hour of walking. And in fact, in my own personal life, I remember my grandfather at one time told me, I walk for an hour every morning. When I get to 45 minutes, I start having pain down my legs. And I told him, why don't you try walking 40 minutes? And he said, great. He was about 80 when that happened. He died at 95. He walked 40 minutes a day, every day in between, and he was fine. So, I mean, it just depends on your stenosis. It depends on how narrow you are. If it's progressing fast and the narrowing is getting worse and the pinching is getting worse and the spinal fluid, then the amount that you can walk starts to be less. So it was 40 minutes, now it's 30 minutes, now it's 20 minutes, now it's 10 minutes, now it's 5 minutes. Eventually, all you do is stand up and the pain starts shooting down the legs. by the time you are that narrow, by the time you are so narrow that you have stationary neurogenic claudication, meaning you just stand up and the pain goes down the legs, you probably smushed your nerves so much that the nerves, it's not just the nerves that go to the legs, the nerves that go to your bowel and your bladder and that control sexual function are also in there. Whether you're male or female, the stuff that goes on requires those nerves. And if they're smushed, you start to lose that functionality. So don't you find it weird when your doctor is always asking you, you're having any trouble with bowel or bladder control or sexual function? They're looking for those symptoms of those nerves being smushed. That's a really, really, really common thing to have happen. And the reason you want to look for those symptoms is, hey, that's time to start thinking about surgery. So Daisy wants everybody to get up and walk, but what I'm telling you is there's some people who cannot walk because of the disease. It's not a matter of they play too many video games or they're lazy or they're fat or they're whatever. The problem is they have spinal stenosis, and this is what it naturally does. As a matter of fact, spinal stenosis is a serious business. We tend, because it happens slowly, we tend to, like the frogs in the pot of boiling water, we tend to think that it's not an emergency. And it's not an emergency minute to minute, but eventually it's a huge problem. The natural history of spinal stenosis, because stenosis only gets worse at some rate. Hopefully that rate is really slow, but if it's not, and you're getting worse and worse and worse and worse, eventually you are bedbound, incontinent of urine, have no erectile dysfunction for men or no vaginal sensation for women, and you cannot walk, you cannot get out of bed, and you will get a urinary tract infection and you will die because you cannot manage your own life. Spinal stenosis is a fatal disease. It's no different than cancer. It's just really slow. And so at some point, that narrowing reaches a time where it has to be addressed. So I find this attitude, oh, well, hey, if you just weren't so lazy, you'd be okay. It's not true. It's a little judgy, right? I mean, calling people fat and lazy and video games, there's a lot of stereotyping going on there. And, you know, judge not lest you be judged. Who said that? It's an important message. Judge not lest you be judged. People are often doing their best, and it's important to help everyone achieve the best function that they can reach. It's really important to get this spinal stenosis addressed. And the way you evaluate it, as per our earlier conversation, is by having an MRI. Could you have a CT, AKA Alex? Yeah, you could, but it doesn't show it very well because we want to see that fluid. So yeah, CT does show, but MRI shows better. So you have an MRI, and unless you can't, then you have a CT. And it'll show us what we need to see with your spinal canal. How do you know with spinal stenosis whether or not you should have an MRI? It's that point at which you can't walk it off. Certainly if you start having any bowel or bladder symptoms. And bladder symptoms aren't just I peed and I didn't know I had to pee. They're I can't pee, I go to pee and nothing comes out. Or I peed and then 10 minutes later I have to pee again. That's called neurogenic bladder, where your bladder is so large because it's never emptying all the way. And so it just fills up a little bit, but instead of going from here to here, it's going from here to here. So you'd hardly drink anything, or you're more frequent. And of course there are bladder issues and nerve issues. You know, it's not necessarily your spine, but it often is. And so you check that with an MRI. And then, so you know to have, if you have bowel or bladder symptoms. If you're having pain with walking that is inhibiting your function, like like my grandfather never had an MRI of his low back. He walked that 40 minutes, 45 minutes, he was totally fine and no issues. So there was really no reason to do anything. He had all those other normal functions. Similarly with my patients, if you're doing well, you don't need an MRI. But if it's inhibiting you, you know, now it's at 20 minutes or 5 minutes or 10 minutes, or my legs feel heavy all the time, or I'm starting to feel like they're numb, or I'm not sure what's going on and I'm thinking about it, I'm nervous about it, I need to do something. MRI, and we can look. Okay, so let's say the MRI shows you have some stenosis. The radiologist will usually rate it from mild, moderate, severe, marked? Mild, none, don't see a lot of those. Mild, moderate, severe, marked. If they, let's say they rate it moderate, well, so that's, you don't need surgery for that. But you want to be aware of these symptoms that we just talked about, or if you hear somebody talking about this issue playing cards, you want to tell them what to look out for. Heaviness in the legs, difficulty walking longer periods of time, shortening the distance that you can walk, and certainly, for goodness sakes, the bowel and bladder control and sexual dysfunction. You want to think about those things. But then maybe you get an MRI a year later. And if that one's okay, maybe you wait 2 years or 5 years. That's called radiographic surveillance. Radiographic surveillance. Once you know something's going on, you put it under surveillance. You know how the cops, they sit there and watch the apartment until something happens, looking for the bad guys? That's surveillance. We're waiting for it to happen. Same thing. We're going to get an MRI in a year. And in the meantime, if anything happens, we'll be aware of it. That's the way to safely manage those kind of situations. All right, well, quite a bit of information there about spinal stenosis. I hope that's helpful. It is a really common condition. One thing I see very often is, spinal stenosis is a surgical condition. Once it reaches, Daisy, you can't walk them out of it. They can't stop playing video games and get better. Weight has nothing to do with it. When you're fat, like I've been most of my life, it has nothing to do with spinal stenosis. Unless you have a condition called epidural lipomatosis, you can actually get fat in the spinal canal. And if that happens and you lose weight, it actually does relieve the stenosis. But traditional stenosis that 99.99% of the people have that you can see on an MRI is due to the thickening of the ligament and the walls moving in of the joints enlarging, and that's not going to get any better if you lose weight. So, that's not the issue. All right. So anyway, if those things are going on, then do seek treatment. All right. Another great question came in on YouTube, and that was from Philip Seidow. Philip Seidow. I hope I'm pronouncing this right. I herniated my L5S1 in my late 20s with chronic pain for decades, eventually developing osteoarthritis. So he got arthritis and degenerative disc disease. So I don't know how old Phil is, but let's say he's older than 20. And what happened is he had a spinal fusion at one level. That's great. And spinal fusion is where the joints fuse, and oftentimes the disc is fused as well. And spinal fusion can be done from the front. That's called anterior, which just means from the front. Lumbar interbody. From the front, you get the disc fusion. And then, or it can be done posterior, and that's where, from the back, that's where it's done with pedicle screws. Either way, the goal is for the joints to fuse and for the disc to fuse. So when people say I had a spinal fusion, they're actually talking about 3 things that potentially fused. The facet joint on one side, the facet joint on the other side, and the disc. Let's look at this really quickly on the model because it's something that's a little confusing. So this guy is now facing you, and let's lean him back a little bit. This is the L5S1. This is where Philip had his problem, and this is the disc. So in that surgery, they came through, made an incision under the belly button, came in to this disc, removed it, put in a spacer and probably a little plate, or screws through the spacer, and that is called anterior lumbar interbody fusion. So now this can no longer move very much. Now we're going to turn him around and look from the back, and we've got the facet joints. So if you have an anterior lumbar interbody fusion, most of the time your facet joints are going to just fuse on their own from lack of mobility. If you have 2 bones, you know how 2 bones, if you don't move for a while, they get stiff? They really do. And if you don't move for weeks and months, they can actually grow together and the joint fuses. So one facet joint fuses, the other facet joint fuses, and then the disc is fused. Now, what happens, so the intention of spinal fusion surgery is that these fusions occur, all 3 of them. But fusion is actually something that you do. The surgeon can put in fixation. they can put in screws and a rod from the back through those pedicle bones to lock them in position. Or they can do like Philip had, A-lift from the front and lock it. But that's actually fixation with hardware. What you do is your bone knits through there and you do the fusion. Well, let's say that process doesn't happen the way that was expected. There's aspects of that can cause stress on the adjacent level or cause pain in the bone. So those conditions can actually, the failure to fusion pseudoarthrosis is not actually painful in and of itself, but the other things that go on can be. And so very often, and Phil has, he mentioned in the note, he has osteoarthritis. So he's got a really good reason to have pain at the joints adjacent to the fusion. So in his case, because the surgery was done from the front, the joints may not have fused, and if they didn't fuse and they were never decorticated, they could still be painful. Or the joint above, because of the fusion below, the L4-5 joint could be painful in and of itself. So let's say these joints fused, but now this is putting extra force on this joint, and now this one hurts. I mean, look, it's not very far, right? It's not hard to imagine that. Let me try to show you that a little better. So let's say his L5-S1 joints are fused, but now his L4-5 is not. And the L4-5 is getting extra force from the one below it. So now the L4-5 is the source of pain, right? So the surgery could have inadvertently caused more pain, or the disease above could have just progressed its spine. It's complicated. So there's a lot of reasons why this may have happened, but it did happen. So how do you address it? Well, one way to address it is with RFA, radiofrequency ablation, right? The treatment for joint pain, the treatment for pain coming from joints in the low back is not fusion. 9 out of 10, if you keep going to the spine surgeon, 17% of patients who have a spinal fusion will have a fusion at an adjacent level within 5 years. So a lot of those could actually be avoided and that pain controlled just by treating the joint above. It's done by a different doctor, though. It's done by a pain management doctor. And you need a doctor who's very sensitive to these issues to make sure you get it right. But you watch this show, so you're the driver of your bus, right? You know what to ask for, and you know how to make sure you get the least invasive, most likely to relieve the pain outcome. So good for you. But that, in this case, would be RFA. And let's turn back and read the rest of Philip's letter now. My first RFA was actually done a month or so before the fusion, but as pointed out, RFA is rarely a permanent solution for facet joint pain, unfortunately. But those 6 to 9 months can be a real blessing. I've had RFA like clockwork every year, and the most miserable time are the several months of pain after the effects wear off while battling with health insurance companies to have the procedure again. Yeah. I'm really sorry to hear this has been your experience, but unfortunately that's very common. A health insurance policy, we don't often realize, is actually a contract. It's not an agreement. It's a legally binding contract. And so nobody reads the hundreds of pages of fine print in these things, but they actually specify that the insurance company will have practice protocols and that they'll only pay for things that are in their protocol. And most of these companies, one way they try to control their costs and their expenses is by setting limits through these protocols on what can be done. So instead of saying, whenever you need it, you're going to get this RFA treatment, they tend to say more, you can only have this so many times within this much time period. And I mean, I'm not saying they're evil or anything. They may just be doing their job. You got to put some limit on something. But when you make these rigid rules and then someone comes along and they need you to bend them, you'd think they would weigh the benefit, but that's not the way it works. It's about the money for the insurance company. No money, no mission, right? Whether they're good intention or bad intention, you got to you got to play by the rules, and that's what they're making the rules. And one of the rules is not just do whatever you want. So it's a little bit of a bad situation, and it leads to a lot of pain and suffering. It leads to a lot of pain and suffering. So I'm very sorry to hear that. It hurts my heart to hear that. But anyway, let's think about, so it's like Philip says, unfortunately, RFA doesn't last forever, and his experience is actually what is expected. Now, if you're going to have an RFA today for some reason, in your mind, how long is it going to last? Well, I think if I asked that to 100 people having RFAs, probably 100 of them would say, well, I hope it lasts forever. Well, I hope it lasts forever too, but it's not gonna, right? It doesn't, that's not the way it works. And let me show you why. Let's go back. I want to show you a really important image, and that is this one. I love this picture. Check this out. So remember our buddy, the spine. This is that spinous process here, the bumps along the back. And then here's the flat lamina bone. And here's the facet joint, this capsule. You see it here. And this yellow thing that's drawn in is a nerve fiber that's going into the capsule of the facet. So we've talked about this on this show before. This is the medial dorsal branch of the spinal nerve root. There it is right there. And that's normally how you feel pain coming out of a facet joint. Now, this facet joint is red because it hurts. And what's this? Looks like a needle, right? This is a radio frequency ablation probe. And it's showing you this nerve dorsal branch is red because it's been burned. So this facet joint, one of the nerves that goes to it, is being burned here by this needle, radiofrequency ablation probe, which is being placed in the spine. Let's look at the layer below. And this one, the nerves are still intact and the joint doesn't hurt, so it's shown like this. You can kind of see the nerve root. See it under there? It's under the transverse process. This is the nerve root. This is a nerve root. This is a nerve root. But this nerve root has a branch, the medial branch, and then it has a dorsal branch that goes into the joint. So really cool image of what happens when you have radiofrequency ablation. Really cool image. By the way, if this was not a radiofrequency ablation probe, if this was a needle, and instead of burning this nerve, we were injecting numbing medicine, then that would be called medial branch. Starting to see a pattern here, folks. Medial branch is that nerve fiber. Medial branch block. Medial branch block, MBB, because we're blocking the medial branch. This isn't brain surgery, right? We're blocking the medial branch, and so it's called a medial branch block. And that's the test that we do to find out whether you should then put in the radiofrequency ablation probe. So if you've watched this show, which you should be if you want to be informed, especially if you have back pain, you better be watching this show. So you know that medial branch block is the test that is done to determine whether or not you need a radiofrequency ablation. And that should be your mental image. That is your mental image of radiofrequency ablation. Now, notice that the nerve root, the medial branch, was all red to indicate it's being burned, but it wasn't cut. It's actually still at the end of the medial branch block and at the end of the radiofrequency ablation procedure, the medial branch is 100% intact, right? It's intact. So if it's intact, it can recover, and it does. And so those 100 people, and all 100 of them, when I asked them as they were walking into their radiofrequency ablation, how long is this going to work? And they said, oh my God, I hope it works forever. I hope it works forever too, but it doesn't. On average, it works for 10 months in 60% of you. So of those 100 people, 60 are going to get good to excellent relief. And how long is that relief going to last? On average, for those 60, it's going to last 10 months. So, I mean, it's just human nature to hope for the best. And, you know, bless their hearts, that's just human nature. And honestly, I think that's one of the very best things about us is our ability to hope and our tendency to hope and look on the bright side and don't be that gloomy guys. Well, I don't think it's going to work. Well, there's a 60% chance that it is going to work. well, even if it works, it's not going to last very long. Well, there's a 50% chance it's going to last 10 months, and some a little less and some a little more. So you got every reason to be hopeful, but don't be dumb, right? Like it's an average of 10 months. It's not magic. And no, hope is not an excuse for stupidity, right? Like we hope it works forever, but it's not gonna. And when it comes back in 10 months, and I'm sorry, Philip, I know this has been a very long answer. I hope this is beneficial, but so now it came back. What are your choices? Well, you want to know if you can have a medial branch block again. So you want to know if you can have RFA again. So they repeat the medial branch block at the end of those 10 months, or 9 or 11 or whatever it is, or 1 week if the pain never went away. Maybe they missed. Maybe those branches are not in the same place in everybody, and that RFA is done on X-ray guidance. They can't see. They see on the X-ray, but they can't see the nerve fiber. So they hope it's right there, but it may not be. So let's say the pain never goes away, or for whatever reason, the pain came back. So you have another medial branch, and the block is effective. So for the 4 hours or the 2 hours or whatever, depending on the kind of numbing that they use, the pain went away, but then it came right back. Well, then you have another RFA. Now, let's say you had the RFA and it didn't work. Now, whereas Philip says, I've been having these for years and I get better every time, or my insurance is making me wait so long I can't handle it, I'm in pain, then what are your options? Well, then it would be great to have a permanent version of an RFA, and there is a permanent version of an RFA, but instead of burning the nerve, you actually cut it. So we go in there with an endoscope and put it right where that probe was, and you can see that little nerve. Let's go back to the screen. So now this is no longer a radiofrequency ablation probe. Now it's an endoscope, and you see that, and you take a little tiny scissors and you cut it, and now it's cut, and the pain can never come back. Now it's a permanent ablation. And I used to call that DVR, direct visualized rhizotomy. Direct because you can see it. I'm sorry, direct because we're going right in there. Visualized, you can see it. Rhizotomy, we're cutting that little nerve fiber. DVR. I thought that was a good title. Other people call it selective dorsal endoscopic radiofrequency rhizolysis. I mean, I trained for years in this stuff and I can barely say it, but it's dorsal endoscopic radiofrequency rhizolysis. So that's fine. That's another term for it. But it's the same thing. You use an endoscope to visualize the dorsal ramus, the little pain nerve fiber, so you can see it and cut it, and then whoop, pain can't come back. How do you get one of those? They're hard to find. It's done through an endoscope and it's in the spine. So what you want to look for is an endoscopic spine surgeon, and then call the office and say, do you do radiofrequency ablation through the endoscope for back pain? And if the answer is yes, that's someone that you want to, that if you're looking for that procedure. Or you can call us, we can help you. At Phoenix Spine and Joint, we help people find the right doctors at the right time. So one of our jobs is to, no matter where you are, we'll help you find, through the internet, through searching. We'll call the office if we need to verify. We can find you the right care at the right time. And it's a free service, something that we do to help. So, and then of course, worst case, come to Phoenix. We know people here who do them. There are definitely people in our community who can help you out that way. I couldn't, I'm sorry, they're talking to me and I can't understand what they're saying. It's too fast. Oh, I'm sorry. There's one last bit of Philip's comment that I need to address. Let's go back to the comments. If this newer, more permanent solution becomes widely available, I would definitely be open to having it. Living with debilitating pain isn't living, it's barely surviving. Yeah, that is the truth. You know, pain is just so horrible and horribly interesting from a neurological point of view Pain is an early warning system. So if pain fibers get activated, it's supposed to tell me there's something wrong so I can pull my finger out of the fire or away from the hot stove. It's a preservation mechanism. Your body is not built for pain signals to last. If you look at the spinal cord, there's 7 pathways that the pain signal takes to go to the brain, but only 3 of them are about the pain signal. You know what the other 4 are about? They're emotion. And that makes sense. You want to pay, you don't want to be like, oh, I'm burning my hand, who cares? No. Oh, I'm burning my hand, I care, right? It's emergency. You want to alert your body to care about it a lot and have an immediate emotional response. But what happens when the system's broken and the pain signal just keeps coming through? It's like pulling your finger out of the fire every minute of every day, and then a week later, you're sick of this message, and then a month later, and then 6 months later, your body is depleted. You're spent. You're depressed. You're desperate. You're miserable. You see all the time, it's kind of like when Daisy says, well, if people would just walk, they wouldn't have spinal stenosis. I hear all the time the same thing. Well, people don't actually have chronic pain. They're just depressed. No, they're depressed because they have chronic pain. It's depressing. It's physical, it's chemical, it's emotional, it's situational. People argue about what causes depression, which one of those things it is. Well, chronic pain is all of the above. So it doesn't matter who's right, you're depressed. If you have chronic pain without depression, isn't there probably something wrong with you? I mean, that's goofy, right? Chronic pain is depressing. It causes you to be sad. So it's definitely not living. And I can tell you from what I understand, Philip, of your case, you are 100% treatable. This is not actually a pain issue. It's a financial issue. It's about getting insurance to pay for the treatment you need, or about getting the treatment you need some other way. So I guess I say that not to make it sound worse, but to hopefully to try to give you hope. There are some conditions of our bodies for which there's just no hope. ALS is one that's like that. End-stage MS, there's Parkinson's disease. There's a lot of conditions for which we can try to palliate them, but we really don't have Alzheimer's disease. We really don't have any treatments that reverse. You don't have anything like that. Your condition is treatable, and that's the good news. It's just kind of figuring out how to make it work financially, and that's the work. Well, we're running out of time. I think that's all I had to say to you today. I did have another comment, another question. Let's see if we have time to get to it. Well, yeah, I mean, let me just push this one till tomorrow. I had a question about my knee hurts and I don't know what to do. This came in through Facebook. It was on Instagram. My knee hurts. I don't know what to do. I can't figure out where to go. How do I even get started? Do I need a knee replacement? What? So that's a really good question, and I'm going to save it till tomorrow. But I want you to think about this for a second. If you have a symptom, like I have knee pain or shoulder pain or elbow pain or neck pain or low back pain, there's actually a lot of potential doctors you can see, and that's going to lead to a lot of wasted money because there's only one. They don't all do the same things. In fact, they have very little overlap. So you got to know when you're going in to see a specialist, and you got to know what's wrong with you, and you got to know what you expect. You wouldn't walk into a restaurant with absolutely no idea whether or not you could afford it, whether or not you liked the kind of food they served, whether or not, no. You would look ahead of time and you would find out what kind of restaurant they are, and then you would find out because you could then decide whether you like that kind of food. And let's face it, you would probably also look up the menu online and have a good idea of what you need and whether that's what you want. Now you're going to go in and ask the waiter, hey, what's better, the chicken or the fish? But you're definitely you want to have some idea of what's going on and at least whether you should be there in the first place. And seeing a doctor is no different. So we're going to talk about that tomorrow. I'm sorry, Delfina Quintero, to put you off a day, but we're going to look at this tomorrow and get back to you and send you a link on Instagram to the answer. Look, you want to be informed. You want to do the right thing. You want to not waste money, and you want to get better, and you want to not take extra risk, and you want to get better faster. So get more content like this. Come subscribe to the channel, to Phoenix Spine and Joint YouTube, and also click through on the link to Best Practice, to our page. Become one of our team. Join our group so that we can send you information, find out which joint you're interested in, and send you the relevant information for that joint so that you can be informed, you can take good care of yourself in an evidence-based way, and help other people you love do the same thing. Have a great day. I'll see you tomorrow for Best Practice. I'm Dr. Dan Lieberman.